good afternoon to one and all of you for our ARC LDP program. And we would run you through this second module of this program today, and are truly lucky to have with us experts on board to teach us a lot with their valued experience. We have with us eminent speakers too, with topics in which they would excel. Our eminent expert panel, Dr. Tulsiraj Ravila, is the Executive Director of Lions Arvind Institute of Community Ophthalmology, as well as the Director of Operations of Arvind Eye Care Systems, is one such personality who could teach you scores of issues on management sustainability and its ever revitalizing agenda. Our next expert panel is Dr. R.D. Ravindran, Chairman, Director, Quality, Arvind Eye Care Systems, an individual who would initiate new centers and newer centers and smoothen out all the wrinkles to deliver the best of services for the community at large. And we need to get the best from him for a very gainful 2 hours. We have with us Dr. Ramurthy, who's the chairman of the Eye Foundation Group of Hospitals, our past president with his awards and accolades to add quality to today's webinar, an entrepreneur going 13 vibrant centers strong with his unique leadership. I'm sure he's going to have a lot to tell us. We have with us Dr. Kasu Prasad Reddy, founder and co-chairman of Maxi Vision Eye Hospitals, again an extremely prolific leader and administrator par excellence, who would be sharing his wisdom. We are truly lucky to have with us Dr. Prashant Garg, who is the executive chair of LV Prasad Eye Institute. He's a consultant ophthalmologist specialized in cornea, anterior segment, and cataract. He's an internationally renowned leader in corneal infections, antimicrobial resistance, and eye banking, and a recipient of innumerable prestigious awards, both national and international. He's on board of several international organizations, societies, and scientific journals, and I'm sure we are going to get a lot from him. Moderating with me are two young, smart guys who are my part of my team of ARC. One is Dr. Satyajit Sinha, who's joined already, who is the director of his ABI hospitals at Patna, an extremely capable surgeon, dynamic individual, and member ARC South, North, East for the second term, and a very popular figure of AIOS. Moderating with me also is Dr. Srinivas Joshi, who is to join soon. He's traveling, who leads his MM Joshi Eye Hospitals, a brilliant VR surgeon, member ARC South, and I believe he is one of the future great guys of our country. Our first speaker is Dr. Tulsiraj, and he is going to be talking on processes and workflow management. On to you, doctor. You could share your screen.
Yeah, I'll do that. Yeah.
All these programs of ours are loaded on the ARC website, YouTube, and Facebook, and a lot of people watch it later on too.
Okay. Thank you, Dr. Chitra, and for the AIOS for this opportunity. Just doing a tech check that I'm audible and the video is visible.
Yes.
Okay, the screen is visible, right? Yeah, thank you. So I'll be spending a little time on patient care and operations. I think right at the outset, I want to kind of reinforce, that good patient care and operations really starts with the mindset. No, that's absolutely critical. In the sense, as the head of the practice or the institution, you really want to ensure that the patient gets better and provide safe and quality care, as well as patient-centered care. And also, I think it's also equally important to recognize that in the caregiving process, the patient is actually an equal or a greater partner. I think we need to have that mindset as well in dealing with the patients, and also recognize that patient is always right. Only then you kind of align your practice to work well for the patient. And of course, you need to match the mindset with different processes. One of which is designing the services to close the care loop. I'll explain that in a minute. Having the right safety protocols, continuous quality improvement, because quality is not a static, it is always a moving target, and it requires continuous quality improvement and putting in patient-centric systems. Because I have seen time and again, and also within my own experience in Aravind, that mindset is what should drive design and systems. When you don't do this, when you just copy something else from somewhere else, it doesn't really work. No, it doesn't really work to the full potential. It might work a little bit, some minor improvement. It is not like substituting an equipment, where a better equipment that gives better outcomes. Here, when you talk about the whole operations, I think having that desire to do it, the mindset becomes very critical. So when you look at operations, we need to be develop this holistic view, that it starts from people who need care. Some of you may choose not to work in those spaces, but then the real spectrum of care starts with the community where people are there. Some of them are able to come, some of them are not able to come, but then to the extent that you own that, it helps. Then when they come to the hospital, you got to diagnose and advise and do a good job of that. And you want to make sure that the patient complies to your advice. Then you get to treat the patient. And quite often the treatment would include a lot of self-care, even if it is surgery, post-op medication, etc. And then finally, you want to follow up to make sure that everything works. In reality, if you see, quite often, most of us define our role essentially as diagnosing and advice. And if the patient is willing to comply or able to comply, we provide the treatment. So I think there is this distinction that we need to become. We should not remain completely reactive, but also become proactive. And to the extent that you can complete this whole care loop, your own practice and the thing becomes much better. So if you want to, I'm just going to jump a little more into patient-centered care. All of us use this word, but it's important for us to understand that because you will recognize in most settings, the patient goes through multiple touch points. From registration, somebody escorts them. You do a refraction, intraocular pressure measurement. Sometimes there's multiple people, or it is 1 or 2 or 3 people. That will depend upon your internal protocol. Like in our case, we've divided the work. So typically we kind of calculate that each patient would have about 15 touch points if they're outpatient. If it is surgery, there'll be several more steps in addition to this. And then what we have to recognize is that each of these interaction with the patient is the moment of truth. And I think if you goof up on any one of this, the concerned staff is rude or doesn't do it well, doesn't explain to the patient or any of that, then I think whatever else you have done to the patient, kind of that importance or the value diminishes. So if you take a hospital like ours at Madurai, where we would see about 2,500 outpatients, you can do the math. Like in our case, there are close to 50,000 interactions every day. About 38,000 on the outpatient. So touch points, when you have 2,500 outpatients and 600 inpatients, you would have close to 50,000 touch points. So this is the kind of the magnitude of what one has to do to ensure good patient care. So what we have done, and this is not being prescriptive, I'm just sharing the way we have decoded it. So patient-centered care is what everyone says, and it's kind of almost like a cliche. But then we also recognize that it really matters. So to operationalize it, you really have to decode it. So we took time, and several years back, we actually laid it down as 10 steps. I'll just quickly run through those 10 steps. And this will be relevant to most settings, but I think every hospital or every practice should develop your own steps. It could be 5 steps, 10 steps, 12 steps, doesn't really matter. But I think to the extent that you can decode it, you can put in systems in place, technology or equipment or amenities, and also train people accordingly. Okay, so one of the things that we realized to be patient-centric is creating access for patient care. Now, the way we have gone about it is kind of having longer window of time, so they don't have to come through a narrow this thing. And then, of course, prioritizing care for the vulnerable patients or those who need emergency attention. And then we don't have an appointment system unless the patient requests. And yet, in spite of it, we try hard to provide all the required care on the same day or the same visit. Like if they come with an operable cataract, all investigations done, end of the hour or two, they're advised for cataract surgery. And if they are willing, they're operated the following morning, and they go home. So you minimize the travel for the patient. And while asking the patient to come again, take a little care to find out if the dates would suit the patient. The second is about maintaining dignity and being responsive to patient needs. So this really requires to be present and listen to the patient. And then in a large setup like ours, there's a tendency to call that one-eyed patient or call that ulcer patient. I think we should avoid doing this, about labeling the patient by diagnosis or their condition, and absolutely no discrimination on any account, because they're dressed shabbily or whatever. And then using respectful phrases. We are from, just as an aside, we are from South Madurai, where the Tamil language that we speak is more, just by nature, just locally, the way we speak Tamil is much more respectful than the way they speak in Chennai. So when we opened the hospital in in Chennai and in Pondicherry, the people there really appreciated just the way our staff was talking, which was just a respectful way of talking. And again, respecting the patient's time. If for some reason there's going to be a delay, telling the patient upfront makes it much more palatable to the patient. And I think it's very important to kind of really work towards informed decision making. Towards this, you need to clarify the patient's role. And we have benefited a lot. We introduced counseling, one of the early hospitals to do it sometime in 1992. And that has become an incredibly important aspect of patient-centered care, to do that detailed communication with empathy and things like that. And when we do this, we have to also recognize that you also have to involve the relatives and the friends who come with the patient, because quite often they are the decision makers, and also they could be your future patients. So involving them in this process, you both have an opportunity to build future clientele and to give better care or empower the current process, decision making the current process. As part of empowerment, getting informed consent is equally important. Especially when you anticipate a doubtful or poor diagnosis, you really have to explain to the patient, and then and kind of come upfront very clean, and let the patient make the decision and take the time to help the patient understand it. I can pretty much guarantee you will never lose a patient if you're going to tell him that outcomes are not going to be, in your case, explaining why it would be. There is no advantage in like promising the earth to every patient, when you know that can't be achieved. And we have benefited a lot by having very transparent pricing, and at the same time minimizing the cost to the patient. So minimizing the cost is not about charging less, okay? Because I think in an outpatient setting, the real cost is in accessing the care by the patient. If you're not completing the entire process within a day and you tell the patient you come tomorrow or day after, that patient is going to spend another 1,000 rupees just to make the trip. So taking a more holistic view to minimize costs, and then to the extent possible, make it transparent. And that is something which patients seem to appreciate a lot. And when you commit a price, and doing the treatment, if you have to invest a little more, do something extra, to the extent it makes sense, I think absorbing it is better than trying to pass it on to the patient. Because I think transparent pricing also takes hold when it is actually becomes operational. And again, we ask patients to come for follow-up, sometimes for a procedure or some treatment you're given, or sometimes for chronic care. And then we often leave it to the patient to do it, and we don't kind of own the process. So to the extent that we can own the process, I think it ensures that the patient actually becomes better, and you can enable that to happen. Like in the early days, for CAM patients, when we used to advise them follow up, and we used to ask them to come to the hospital because we operated them in the hospital. We used to have a 20-25% follow-up rate, which we felt was not optimal. So then we decided that we would do the follow-up at the campsite itself. So now for every camp, there is 2 visits. One visit for the screening and the other visit for post-op follow-up. And the follow-up rate is around 90% plus. And since we have vision centers now, we also do the follow-up at vision centers. So all of this is making it easy for the patient, and that can only happen if you own this process. And then what is really critical is for you to know how well you are doing. Because otherwise we'll just assume that whatever you're doing is the best. So unless you're able to get proactively inputs from the patient, some of it could be suggestion books, which will be a passive method. Not many people really write in it. But then satisfaction surveys, focus group discussions. Like in our hospitals, we would run every day 2 focus group discussions. Now basically get 7 or 10 patients. There is no scientific method for that sampling. We would do that in every service by rotation. And they have to be willing, of course. 40, 45 minutes, have them sit around, ask them what went well. Initially, they'll all be telling good things because they don't want to be critical. But later on, when you keep probing them, one person will prop up saying that, oh, this could have been better. And then you get really areas where you can really improve. Otherwise, you're putting all your systems kind of shooting in the dark. And of course, amenities, which is straightforward. I think all of us are familiar with this, and you should do this appropriate to your setting and your context. And then recognize that sometimes whatever we do, there would be issues, at least in the way the patient perceives it. And I think it doesn't help at all to get defensive and argue about it. I think if the mindset is that, okay, this is what the patient wants, which means this is what I should have done. So this notion that patient is always right, or in the business they would say the customer is always right. And I think then you can kind of sit back and reflect as to how things could have gone better. And that way you kind of retain the patient. And quite often those patients, when they get this kind of a response from you, become really your advocates and ambassadors. And finally, I think when you have all these things in place, patient feedback, listening to patient, all of that, and data, on different metrics, patient feedback and things like that, you should have a process of continuous improvement. You have the data, you discuss it, and then you say, okay, how can I move to, from 50% excellent to how can I make it 70% excellent? I think that journey is what will continually improve the care process. So finally, I think what matters is that the patient gets better. And for that to happen, you got to close the loop and plug all the leaks between diagnosis, compliance to follow-up. And I can also tell you this is what will retain the patient. And then all of you will recognize this is where the revenue also comes from. you get some revenue at the diagnostic process. You get much larger revenue when your patient complies with your advice, to follow through with the surgery or buy medicines or glasses or whatever. So this is really a win-win kind of a proposition. So making sure that all your systems, and like I said, starting with the mindset, is aligned to the systems. So with this, I'll stop. Thank you. And I guess we'll take questions at the panel time.
Yes. Thank you very much, Doctor. That was a great talk. I would want thoughts from our panel on just a few of the questions I have put together. Some Satyajit could ask, and I wouldn't mind the panel themselves coming up with some aspect which could be discussed better and bring up those points. So my question is, who should be managing a practice? I think I would start with asking Dr. Prashant Gar, who would give a different viewpoint. Who should be managing a practice? Should it be an ophthalmologist only, or should it be a healthcare training professional? Because it seems to have become a full-time appointment, this kind of work. And how do you manage the conflicts between the two if both are to be managed? Like in mid-sized practice, small-sized practices, the same doctor has to manage that. Even in a larger practice, should the doctors be involved, or should the professionals be involved? You have to unmute yourself, Dr. Prashant.
Yeah, no. So I think, Chitra, thanks for asking that question. Management of large organizations differ in some way from managing a small organization or practice. And this complexity comes from the magnitude of the operations that one has to look for. Clinician at the helm of the affair has a lot of advantages. One is they know what kind of practices a clinician gets facilitated. They have the complete idea of the different aspects of the activity, and therefore they can really guide the manager on what different components of the clinical practice one has to go through. However, their involvement into day-to-day affair will distract their time from the expertise that they have acquired over time and the training that they have. So to answer your question, I feel that the best approach is to have the two group of the people working together, where clinicians set their expectation on the table and the managers give them what are the best practices in industry that will make the process efficient. The ultimate aim or objective has to be to deliver healthcare through or in an efficient manner. So in our organization, we have slowly started working with both. While I'm the executive chair, my role remains mostly to set the ball rolling by putting or defining what kind of services we are going to provide and what is the process that a clinician expects to be in place. However, then we take input from the managers on understanding how to make these processes efficient. So I'll not put ball in one of the court, but rather give responsibility to two and letting them do their task in efficient manner.
Yes, Srinivas, you wanted to ask something?
Yes, madam. Tulsi sir, wonderful presentation as always. Sir, nowadays we were doing it, the book-based patient complaints, what you were talking of. But present scenario, since the digital era and digital marketing is growing on, so filling up again in the notebook and again going on in the Google review rating, how is it definitely going to help us, sir? Because making a double entry for the patients, they are really not happy. So does this Google reviews and rating really make a sense in the two-tier cities?
Dr. Srinivas, I think my answer would be really a big yes. No, I think today patients have a lot more avenues to voice their happiness or dissatisfaction. No, so I think you really would have to invest in having someone monitor this. I think any new patient, today they by default, they kind of look at these reviews. Because they just pop up. You just type Arvindaya Hospital, or even if you go to the Google map and type Arvindaya Hospital, along with the location, the reviews also pop up. And I think if somebody is going to come there for care, they're definitely going to read it. So it is really we really should invest in monitoring it, and then also replying and getting in touch with those patients.
So you mean to say we need to make a book entry also, and then
not necessary. I don't. This is not really a clerical exercise. No, it is more about knowing the feedback and acting on that feedback. So I don't think you should look at it as a clerical or an administrative this thing. Now you're hearing the patient's voice. Either they're entering in your book in the hospital or they're taking to the social media. So you have your hook into wherever they might be talking. And your own staff also now post things in different places. Shut doors. There's some such site is there about for staff employment. So they also write good things, bad things about the organization. So you need to be aware of all of that feedback that's happening.
And actually, while 1 minute, Srinivas, I would want your things to continue. But the breaking the link, I wanted to complete that part which Dr. Prashant Garg had started. What I wanted a word from Dr. Reddy, one word from Ramurthy and Dr. RDR about combining management professionals working with the clinician. Is that the future? So then should this management training also become a part of the curriculum of ophthalmology is the question. I would want each of you, Dr. Reddy, you could say something so that before we move to the next question.
Chitra, I think, it's extremely important that it should be doctor-centric in the sense combining, yes, we combine both the doctor and the manager because doctors don't have time to attend everything. But at the top of the helm of the affairs, you should have it should be doctor-centric. I think, sometimes failures, sir has just, presented. Yeah. In that, I would have loved to hear how do we handle failures? Yeah. Because, the happy patient, there is nothing to handle. He comes, he goes. They don't even complain about waiting time. Happy patients. At the end of the day, this is the unhappy patient who has, a lot of complaints. So how do we handle them? That is the key to success, I think.
Dr. Ramurthy?
Regarding your specific question, of course, especially in bigger hospitals in chains, it's extremely important that we have proficient managers who are really qualified to handle it, controlling the day-to-day operations of the place, guiding the workforce, and doing things which doesn't require a clinical acumen. And it's extremely important that clinicians and these management staff interact and understand each other and work in tandem. Having said that, it's also extremely, I think your question was whether the doctors should have some basic management training. I think we are taught all of ophthalmology, all surgery, all of our conferences, meetings are about that. But I think 50% of your time is spent upon managing people, managing our things which are outside the purview of the books that we are familiar with. So I think it's extremely important that going forward, the doctors also become familiar with management aspects, and it's important that this becomes part of our curriculum too. But I have a couple of questions for Dr. Tulsi Raj, if I may.
Yes. Yes.
Excellent presentation, Dr. Tulsi Raj. Just I have two queries in my mind. One is your volumes are tremendous, and not everybody has that kind of a practice. Do you think what you said, the kind of systems that you have put in place, is relevant to even a small practice? For example, you said you don't give appointments, your approach to patients, but where a single practitioner or a small group of practitioners who are essentially catering in a urban or a semi-urban setting to patients who come with appointments, want the higher end procedures to be done. Will this work? And the second is that you have been in this business of ophthalmology for almost 4 decades. And do you think your approach has changed from what you're doing, say, in the 90s to what you're doing now? For example, most of cataract practice in the earlier days was cataract-centric. And now we know that just forms as one segment. We have much older patients, glaucoma, age-related macular degeneration, diabetic retinopathy, etc., which require much more intense follow-up. And there are also nuclear families where the caregivers, especially the children may not be there. You feel elderly couple or sometimes just one of them walking in for treatment. So how has things changed in your own professional lifetime from what you're doing 20 years back to what you're doing now?
Okay. So to me, the answer is yes to both, but I'll explain in a minute. You said when you have a very small scale, like a private practice and a niche practice, does this level of systems administration apply? In a sense, it does. But then you may not need to have very explicit, because your line of control can all be visual. But I would still say that given today, given the complexities of today, like say the earlier days, you build something and maybe the doctor himself or herself just collected the money and put it in the drawer. That can't happen today because most of them are insured. And if the doctor sits and does the paperwork, I think you can forget your practice. And then same way the regulations, this license, that license, this compliance, that seems to apply for at all levels of practice, not only big institutions. So you really need to have certain systems. And then to the earlier question, you really need to have a person who can deal with all these things efficiently. But I fully agree. I also strongly believe that I think at the helm of it should be the doctor. And like you very rightly said, for that purpose, the doctor should have a fairly good idea of management, understand some of the terms. So in fact, we recognized this almost 3 decades ago, and I've been running a course every year in January, which is very popular for heads of hospitals, predominantly ophthalmologists. And second, how has ophthalmology changed? I think at one level, when you look at the clinical practice, of course, it's been night and day in terms of the technology, the breadth of diagnostics that you have, and the treatment options that you have. There is a tremendous amount of change in that, as well as the patient expectation, the staff expectation, all of that has gone through a sea change. But then at the core, some things haven't changed at all. In the sense, I think to the extent that you become more proactive in finding patients, making sure you're building that loyalty in the patient, you're owning their problems and closing the care loop, which we have to do different things now. But I think those that fundamental foundational things, I don't think they have changed, and I don't see it changing. Because I think whatever technology or whatever it is there, a patient coming with a problem wants to get better and he wants to enjoy that experience of becoming better. That is not going to change. So I think from that perspective, I think things haven't changed. But then how you achieve that satisfaction to the customer, those details will constantly change. Yeah. So that's how I look at it. Yeah.
Dr. Ravinder?
Your question, Chitra, it's an important question. I mean, it's like a teamwork. I mean, in addition to the doctor and the manager, we also need to empower the technicians who are involved, the ophthalmic nurses, the counselors, the people who are in the reception, the registration. I mean, they have to be involved. When, as the Tulsi was saying, the doctor, maybe the chief medical officer or whoever heads a particular department, the particular doctor should be aware of all the patient care principles, like what Tulsi mentioned. So all those 10 points, there are also other patient care processes, like how do we ensure the safety for the patient? And there is an aspect of how do we make sure that the clinical care we give is also effective. I mean, that's where the doctor has to really focus. I mean, and and the doctor has to make sure that these things are put in place, which also needs certain level of human resources, making sure that you have that adequate human resources, the practices are in place, and the staff are trained, they are understood. That's very important at the highest level. So once done, I think it does the next level, which is the ophthalmic technicians, we call mid-level ophthalmic personnel. They should be really empowered to implement them. Sometimes you can teach them, train them, but if you don't empower them, if something goes wrong at a particular point, as like Prasad Reddy mentioned, before it becomes a crisis, how they can manage. I think that is where some of the senior mid-level ophthalmic personnel technicians have to take the responsibility. I think the manager's role must be to really monitor, the feedback, what happens, where this particular department stands. Is there a lacuna in the HR? Is there some kind of a training is lacking, or some new process is being changed, and how do they implement it? I mean, that's where the manager's role should be. So I think it has to be a teamwork. I think we should not forget the role of the technicians they play. I think they are very important. So.
Srinivas, you were continuing a discussion.
No, I just want to congratulate Tulsi sir and RDR sir, is because I was doing a short course of IIM from Calcutta, and the lean management and the constraint management, what Arvind system has brought up, I think that has become a role model kind of thing, and it's been discussed in the most of the IIM schools, and I think we are proud of it being in the eye care sector. It's the example taught to almost all the doctors in India. I think I just want to really congratulate both of them. Thank you.
Thanks, Srinivas.
Okay, one point, Zitra, one is, Tulsi mentioned about the 10 points. I think, each of the hospital, as Tulsi said, you have to see how to customize it. And again, these are all kind of vague unless you know really some data points as to whether it is working or not. For example, you talked about access. So one of the things we see, how many patients registered in our hospital and left without seeing a doctor. Okay, so which means, if that numbers, there are reasonable, it's okay. If there are much more, then we need to understand what went wrong on that day. How many patients you asked, general OPD, you go and see the retina doctor, glaucoma doctor, but that patient did not go there. Okay, how many of them did? That follow-up, that kind of a data collection is very important. And again, the data also becomes very important, relevant only when you do a benchmarking, either across time or across departments. I think if that happens, then that can be a very powerful motivating factor for the department and for the staff.
I have one different. Yes.
No, Dr. Ravindran, this has been our challenge too, of course, in a much, much smaller scale. That is, we have been trying to set standards across all hospitals. Some of them have been around for some time, some of them are newer. And always benchmarking and trying all of them to reach the same level of proficiency and care delivery is a challenge. I think, we don't compare ourselves with the outside practices, but within the system itself, whether all of them are performing equally. How do you find in your own system? You have much smaller centers and major centers. Do you think they all fall in the same category? Is there a wide variation depending on the competence of the person leading that institution, the size of the place, the location of the place? There's a lot of variation.
Definitely, it varies. A lot of that is usually we see the differences mostly in the type of care we give. Like you were saying, glaucoma, retina, cornea. We have about 7-8 departments. Across departments, there are some similarity. What is important is whether that department group really discusses what is not going well. That's very important. Rather than achieving that endpoint is important, but understanding what is going wrong and what steps we need to take. How do we implement it? Is there any progress we are making? That's more important than actual numbers. So, which also means, how the people get involved is more important. Yeah. That's where I use the data, not really for really achieving that point. Once you achieve that point, you also relax, and that's not really good. So
Ramurthy, I just want to reinforce you that the variation is actually good news. In the sense, if there is no variation, then of course the data becomes questionable. But I think variation is what really drives improvement. And it will continually raise the bar. That's how they, and because the people it's much more real. Somebody is like we would, for example, we would benchmark, let us say, cataract advice rate or cataract acceptance rate, against OPD visits. It's just a metric, but we know it's uniformly applied across each of the hospitals. When we see variations, we'll ask them, what's happening? Are you guys underdiagnosing, overdiagnosing? What's going on? So it's a healthy discussion. And the ones in the extremes, I think there'll be a lot of learning that is possible. The highest versus the lowest. So I think that's what makes the game continually go up. Yeah.
This has been our experience.
One question I'm going to take on more because we have to go to the next speaker and then we can come back for the discussions again. The last question, I'm again going to ask Dr. Prashant how he looks at his place. Like, we know that time gets consumed a lot if we are, the time taken per patient is quite a lot. And we start compromising, then the quality becomes deleterious. So do you create a middle path where some of these patients are put on a fast track mode where they require less evaluations? Are you able to get them out of the system faster, or all of them come in the morning, go back in the evening only?
No, so we have a system where we are giving appointments to most of the patients. So we have a very well-designed appointment system, but we also have within the system built-in patients who are coming without appointment that have been referred from outside or have an emergency. Now, there have been, when the patient comes with an appointment, another philosophy that we have adopted is that their first examination should start within 20 minutes of their appointment time. And we expect that within 2 or 3 hours, they will be out of the system if this is a case that does not require a cross-department consultation. The patients are told at every level that what is the kind of time they are likely to face. And those who require a cross-department consultation, they are given that counseling that you have a choice of going for today or. So on the electronic medical record, everything, the movement of the patient is clearly visible. We went through the phase where the system got little screwed up. There was a lot of influx of patients who were coming without appointment, and they were really causing a lot of crowding in the time frame of, say, about 10 to 1 o'clock. And that was leading to displeasure among the patients who were coming with time. And therefore, we had to take that change. Despite all the systems that we put in place, there are patients who come late beyond their appointment time, and how do we deal with them becomes a big challenge. We even thought about that, can we incorporate that these patients will be told that based on the next available slot they will be seen, but that looks too traumatic for them because many of them are coming from far off place and they do not have control on the transport and other things. So we still do not have answer for that segment of the patient who are delayed more than 1 hour from the time of their prior appointment, and we still are working. But I think with the limiting the number of appointments per hour, accommodating or bringing in the slots for the walk-in patient has helped us making sure that close to 80% of the patients' first checkup starts within 20 minutes, and then in 3 hours, they are out of the system.
Dr. Ramurthy, would you want to add some thoughts to this?
I think almost everything has been covered at different levels. Our experiences have been very similar. I just want to echo what Dr. Tulsiraj said. I think, we have best performance metrics for almost each and every department, whether the number of VR consults that happen, number of surgeries, number of FFAs, OCTs, OPD to the number of glass conversions, And what is, as you said, cataract counseling to work up to number of surgeries that is done. You have some hospitals within your own system performing at a certain level. They are reaching 85, 90%. But there are some other departments, hospitals where it's 60%, while maybe the opticals might be doing 85% over there. So it's good to point out that, having very similar practices, having very similar kind of setups, similar facilities, somebody is able to do much better. My telling them is, Arvind is seeing 2,500 patients. Why are you not seeing so many? It doesn't make any sense. We are not geared up to see so many. So what works for us is to tell them that this is what your peers, within our own group, we are doing it. So why not measure up to that? And that we are not doing it even a couple of years back. Now there is free sharing of information. Everyone comes to know how the others are doing. And that keeps them positively motivated and try to reach up to better levels. Maybe single practices can adapt something similar by comparing it with how their friends are performing. And I think benchmarking yourself with people who are already doing well would be the right way to go, because setting unattainable goals will also not work. So we need to have reasonable goals, targets, and appreciate it also when they achieve it, and it works reasonably well for us.
I'm sure there could be a lot more questions which could be asked in the processes. We'll just hold on, go on to our next speaker. And I would want my expert panel, because the audience is also a young audience, who are young practitioners, who have urge for leadership, urge to grow, urge to do well. So I would want some of our answers to cater to their needs also, rather than looking at it at a very expansive phase. So I would want Dr. Satyajit Sinha to introduce our next speaker, Dr. Wail Rajshekhar.
It's an absolute honor and privilege to introduce our next speaker, Dr. Wail Rajshekhar. I've known him for over 2 decades now, and what an amazing gentleman he is. He is the medical director and founder of Shekhar Eye Hospital. He is a great administrator who leads Vasan Eye Care System at one point to greater dimensions. He would be talking on hospital models, strategies for a successful mid-sized practice. Dr. Rajshekhar Wail.
Thank you, Dr. Satyajit. Am I audible?
Yes.
Yeah. Thank you, Dr. Chitra ma'am. Thanks the entire AOS team for this opportunity. So I was just enjoying the good discussion that was going on. I was wishing that the same discussion goes on. Yeah. I'm interpreted, the talk has come. Yeah. And taking a leaf out of what ma'am said, I'll be focusing more on young entrepreneurial doctors who would be either starting their journey, or they would have just started their journey, or some people who want to scale up their journey. The topic given to me is hospital models, strategies for a successful mid-size practice. So here, there are one is models are coming up, then strategies, successful, mid-size, all these things. Here, I thought, let me focus on the solo practice, or a small group practice, or a practice which can cater to secondary care, and probably a single unit or 2 units having tertiary care ones. In my talk, I would be avoiding corporate or charitable ones, or the ones which have big chain, because the talk to them would involve a different set of topics, maybe the similar ones with a different perspective. So the mid-size I would be covering or catering to those who have staff numbers of say 100 to 200, or maybe 200, 100 to 10 to 100, or maybe up to 200. And OPDs less than OPDs and surgeries less than 300 to 500 per month. OPD varies from place to place depending on the location. Those who are having 1 or 2 centers, or maybe max 3 centers, because the same things may not be applicable in a different practice. The success of a practice, the definition itself, what is a success? For some, getting more money might be a success. For some, getting more patients might be a success. But success should be a sustainable one. It should be all-inclusive one. And it should have a growth. It should have an ethical growth that's coming up. Here, when we are talking of success, we should talk success of all the stakeholders. So then who are all the stakeholders in our practice? So patient definitely is the main stakeholder. Apart from that, the staff who work for the hospital are also stakeholders. The society in which we work is also a stakeholder, because if they say that so-and-so hospital exists, they also see what impact it has on them in a positive way and in what way they can rely on them. And Mr. Money, from whichever source it is coming, your own pocket or the bank or an investor or something else, that's also a stakeholder, because the money itself needs to be done justice to. The vendors and the industry are also stakeholders, and the doctor, I have deliberately put it at the bottom, because we shouldn't miss out the other stakeholders by putting doctor or the medical community in the first. So not only a doctor, but what kind of an impact this doctor is having on his other medical community is also an important one. Then what are the essentials of this success? So if you have to come to the essentials of success, you should know the stakeholders' interests, because each one's interest is different. Mr. Money's interest may be different from patient's interest. Staff's interest may be different from the medical community's interest. So when we take each one's legitimate interests into account, then we need to draft what are all the essentials of a successful practice. So by taking into account each one's perspective, maybe we can jot down things like quality of care and the value for money, as less expensive as possible. That doesn't mean cheap treatments, but it can't be unnecessarily expensive for a mistake done by the practice or for a mistake done otherwise. Like Dr. Tulsiraj was saying, if a patient has to come back for the same small treatment again and again, or if he has to run around 10 places to find a medicine, then you know that overall it adds to the cost of what he has come for. So, and hence should be as less expensive as possible. Return on investment is a must, otherwise financial sustainability won't be there. And the meeting of the financial commitments, whatever are the commitments, and as long as these commitments are within one's reach, and as long as one doesn't have too much expectations comparing with other industry standards, then that's another important point. Professional satisfaction is extremely important here, especially in places where multiple doctors are there. Each one has been employed and they would have come from different, what we have seen is people have a different way of approach to a patient depending on from which cultural background they come, which training institute they have come, and what kind of an exposure they have had in their family circles. So putting all of them, bringing all of them on same page and bringing them patient centricity and bringing into a vision of the center, vision of an hospital is again a challenge, and that's very important. So, and professional income must also be commensurate, because these days young doctors tend to compare their salaries with their friends who are in non-medical streams. And hence, you know, some kind of a balance has to be brought in. You may not be able to match it always, but at least an understanding of the situation is important. And we need to uphold medical standards, because whatever we are enjoying today, both good and bad, is what has been done in the last few decades. Taking that into account to eliminate the bad and to increase the good, we need to own up that. And each practice should have some amount of teaching and some amount of research, sharing their experiences, so that the next generation will be better. A part of the topic is also about strategy. So now vision, mission, and purpose, the new thing that has come is vision and mission. Each of us will write down, but we also have to script down what is the purpose of the entire organization. And this purpose should be driven across the organization, however small the organization or however big the organization. Then, you know, achieving success becomes easy and worthwhile. Now, coming to the strategy. So many people talk of strategy. So from whatever I have learned from management gurus, here we can discuss it later. So you are at point A now, you want to go to point B. There may be multiple ways of doing the same thing, but which route you will take, and for that, what are all the things you are prepared with, and how efficiently or how you want to reach there. That's the strategy. So whenever strategy comes, a lot of options will come up. If there are no options, then it's easy. Then you will have to do the same thing. When there are options, then you have to make a right choice. Once you make a right choice, or whatever the choice you think is right, then executing it becomes an important thing. It's looking at the options, making the right choices, and executing it becomes the core of success. But while doing this, we should keep in mind the stakeholders and the objectives, the essentials of success in mind. Otherwise, we may go wrong. Many times, if you are discussing this strategy with finance people or people who are not so concerned about the healthcare itself, then it will be mainly with regard to the finances. Then you may be cutting corners and making some other mistakes, primary mistakes, which should not happen. So, and hence it should be all encompassing kind of an approach. That's where this strategy comes. This is where the top management role also comes in. Like Dr. Chitra was asking whether an organization should be headed by a medical person or by a non-medical person, which is the ideal one. This question came because in healthcare, neither one is the great choice, or there was no unanimous kind of a choice, because a medical person must have administrative skills, and administrative should know the medical skills. But to my mind, whoever is there, as long as they know what they do not know, and they can draw that kind of information from the other person with an open heart and open mind, then and keeping in mind the purpose of the organization, overall purpose of the organization, then that should be a great leadership. A medical person should know that he is not the best in the management, especially if he is clinically practicing. He cannot give time. Those who are in the top of management things, managing too many people, then they should give a lot of time to it. Some tips while making these options, choices, and executing. You should know your strengths and weaknesses, and get it validated from your friends, because we think everything is our strength. Let our friends and people let us tell our blind spots. Have clarity in what you want. See, today you want something and tomorrow you want something else. It's not possible. Then you won't know where you have to reach. And then these days, many people see an organization doing well and try to copy paste things. You can copy certain things, but you can't copy blindly, because what is working in one situation may not work in the other situation. So just being a good doctor is not sufficient. If somebody knows how to do a good surgery and is a good doctor, to run an organization, that is not sufficient. Somewhere as medical professionals, some ego gets into us thinking we know the best. Intelligence wise, we may be better ones, but unless we are exposed to the management, then that's a different ball game. We may not be good at that till we learn those steps. And even if you learn those steps, we can't master, because we are not doing it for a long time and we are not doing it as a full-time thing. So it's not good to wear multiple hats. That's because we have that ownership as well as leadership. We have the authority, but that mistake we should not be doing. Leadership is much beyond power. It's a responsibility. So it's responsible to all the stakeholders to achieve that each one is getting the benefits of the organization that's being run. However big you are, it's better to have mentors and also be a mentee, because then you can learn more, tell your newer ideas, get some inputs, and get it validated and go forward. We should also know our industry specific information with regard to the healthcare, because what works for automobile industry may not work for healthcare in total. So, and hence we should know what is it that a best industry, what are the percentage profits that can come up in healthcare by doing an ethical practice. So that kind of an information is required. Unnecessary and unreasonable comparisons are not good. And always you should be ready to unlearn and relearn. This is one thing. What has worked yesterday may not work tomorrow. So it's changing, and a lot of disruptions are happening. I wish Dr. Chitra and ARC team will come up with some discussion on these disruptions that are happening. So how can it affect the healthcare? Certain things don't change. People won't change. The way people act won't change. But what people look for and their options will change. And hence, that's another thing that a practice which is now trying to gear up or trying to set up should keep in mind. nobody should come under financial pressures. This happens if you copy paste other models and invest unnecessarily and try to match. You should not come under financial pressures. And most importantly, in healthcare, you should not be in a hurry. There's nothing like an end point where you enjoy. Each day should be complete in itself in terms of what you are doing, where you have delivered to all your stakeholders and you have taken what you really deserve. What has not come, its time will come. So, and then for those who are wanting to set up, then location is an important thing. You should do good market survey, not that you have your own land and you start there. Whether there is a need for so-and-so requirement in the society, what is that you are going to do better there, how unique you are, all those things, some kind of market survey is required. Here, getting an expert team and talking to multiple people will help. Otherwise, our own biases will cloud us and make us think what we are thinking is the right thing. Affordability of the people is extremely important. So when you start a healthcare, it's all about people. It's all about people. Your patients are people, staff are people, doctors are people. It's all about people. Unless you know, and they come in various shades and shapes, various mindsets. What is right for you may not be right for the other guy. So you should know how to manage people very well. Cost sensitivity is across there. Any country you take, any culture you take, cost sensitivity is there. So, and hence having good processes and systems in place is very important. Patient centricity is not an option. Quality is again not an option. And doing ethical practice is most important, because that is one thing which will give success in the long run. That success will be self-sustaining one, and it will withstand any kind of internal and external changes that may happen in the marketplace. Skills in the team, medical skills is what each doctor comes with. Apart from that, excellent HR skills means you have to bring in that skill into the team, not that you read and acquire. Yes, you can read and acquire, but you cannot match a HR who has sufficient experience. What is thumb rule for him may take ages for you to read and learn. So you need to bring in that skill into the team, HR skill, finance skill, operation skills, marketing and branding skills, and you should have a clear-cut strategy. Thank you very much. And thanks for the opportunity once again.
That was a wonderful talk, Dr. Rajshekharan. Every single point of yours had so much value. You could actually sit and discuss each of them. But I'll just start with the question with you, and then I'll have to go on to the expert panel. Wonderful talk. How important would you say advertisement in a mid-sized practice be, keeping in view the economics?
Advertisement will not work in mid-sized practice, ma'am.
Yes.
So you need to focus on each patient that comes, and whether each patient has become happy or not, whether how likely he is going to refer you back another patient is what is important in advertisement. But certain kind of advertisements, like having a good website and giving that online presence, is extremely important, and it is doable.
Yes.
What is not good is going on Facebook ads and these other kind of online advertisements where you burn your cash, because your reach has some geographical limitation. So though they say that you can customize advertisements to that place and all that, it's not cost effective with the present kind of systems.
And maybe you could also answer, and I could ask Dr. Karthik Prasad Reddy also to answer. Once a person is established in one center, is there a need to go on to different centers and different populations and different locations? Is it what, after years of experience in this, what would your message be for the younger practitioners who are watching us? What should they do? Dr. Reddy?
Chitra, I think, first of all, let me thank Dr. Rajshekhar for a very educating talk. Especially, I loved when he said, leadership is not, leadership is responsibility and not power, which is really a great thing to say. So starting from there, the question you just asked, what's the question, please?
Like if you're successful in one center, would you want to go on to reach out to different centers or different populations?
Well, I have done it. I mean, I'm sure Ramurthy has done it. A lot of us went around to different centers, and people still flocked to see us in these other places. But that is a different scenario. But coming to one, as we are addressing young population of ophthalmologists, and they're all going to start with what Rajshekhar just said, a mid-sized, eye centers. Obviously, it's not a good idea for them to leave their place.
Yeah.
Just stick to one place. And like he said in his presentation, word of mouth is the best, advertisement that you can do. So that word of mouth to happen, all you need to do is apply what all Sir Dr. Tulsiraj has spoken and Dr. Rajshekhar has spoken into practice, sitting in one place. And believe me, that will take them a long way.
Yes. I have one other question which I would ask Dr. Prashant and Dr. Ravindran also. How could a person in a mid-sized practice upgrade his skills, his academic involvement, instead of getting lost into his practice? What would you advise them? The fact that they have joined this leadership program itself is a reflection that they want to go beyond what is there with them. So how would you advise them? They have to run their practice. Some of them might be having help and guidance of colleagues, some may not. How can they keep themselves upgraded?
I think the continued medical education is one of the very crucial component of being a successful professional.
Yes.
And we need not look only at the doctors, look at the judges and the lawyers, look at successful engineers, and now today look at successful businessmen. They also go try to meet other colleagues, understand good practices, and if required, even go for enhancing skills. Now, to that extent, in the healthcare field, this is even more important because the knowledge is constantly evolving and changing, and the new skill sets have to be acquired if you need to be having a pace with the changing environment. So every practitioner, every clinician, every healthcare work person has to build in their calendar time for the continued medical education. And I think that's probably the best way that we can keep it.
Yes, Dr. Ardia, your thoughts?
It's important that they constantly upgrade their medical knowledge and the skills. It's very important. Today, it's also easier to acquire because of all these virtual meetings. And going to the different hospitals, specialty hospitals, and seeing some of the surgeons who are really good at it is good. We also make it a point whenever our doctors go to America or some Europe somewhere, I think make sure that they spend 1 or 2 weeks in the hospitals observing the doctors. That's important. Equally important is also if the person is running a hospital, heading a hospital, understanding the management aspect, leadership aspect is also important. I think the third point is, I think we need not only look at eye care hospitals or ophthalmic hospitals. I think there's a lot we can learn from other specialties also. Today, there are really good landmark standalone specialty hospitals are there, where again we can also learn, and also from other industries. So, how do we apply those principles in our practice is what is important. And other thing is, one is that person learning on his own, but also how do we give the same opportunity to the team? How do we expose the whole team also to that is also becomes very important.
And that's the only way we could keep the team together. Dr.
Yeah.
Ramurthy, would you have anything to add on this before we have to move to the next talk?
Very nice talk, Dr. Rajshekhar covered a lot of important points. I think one of the most important points you made was the location of the practice. And especially, of course, this is directed towards the younger practitioners. Many of them flock towards metro cities, places which are already crowded. My piece of advice would be that go to places where you are needed rather than places where you feel you need to go. I think as far as your location of practice, maybe small, start in a smaller place in a peripheral center. And right now, even tier 3 cities, tier 4 cities, there's information. People are thirsting for good medical facilities. When you set up a practice there, immediately you have a setup. You feel that you can build up your practice. And as many of us have done, maybe from those smaller centers, you can move on to bigger centers once you are successful there. So I think rather than getting into a crowded space, going where you are needed gives you a big boost right in the initial stage. And that applies even today, where we feel that there are ophthalmologists everywhere, but still there are underserved areas. Going there would be a good way.
Sudhir, I'm going to ask you a question. You may not be expecting it, but how does a young practitioner market himself? Like we heard that he cannot invest on advertisement, maybe digital marketing, maybe on that kind to a small scale he could do, he can bring himself importance. Word of mouth, of course, continues to be the best way in all categories of practice. But how can he upscale himself? What would you tell him?
Madam, thank you for the question. Can you hear me?
Yes.
Yeah. So a younger practitioner, as soon as he is out of the institute, he should primarily focus on upgrading his skill set and send out maximum good results as possible, and make every patient the initial set of patient and as an ambassador to bring back more referrals to him. And once he establishes a strong patient base, this always works on between the family, word of mouth, and then slowly start investing on spreading his profile across digital media. Yes, digital media is one of the options where we can restrict the regions, or you can do digital marketing in a particular region. But ATL advertising, I wouldn't recommend for mid-size upcoming practices, because it's going to be very costly and it doesn't serve a particular region. It goes across and it may not particularly direct patients to them. So patients should be, the doctor should promote more of his skill sets and the support system, the quality of the surgeries, the care in the floor. These are the things where he should focus on, spreading this communication through various channels, whatever is possible as per his locality.
Yes. Thank you. Thank you very much. That was exactly what I wanted to hear. Dr. Srinivas, are you there with us?
Yes, madam. Yes, I'm very much here.
Dr. Samina.
Yeah, sure. So, good evening, everyone. It's been a fantastic webinar so far. And our dynamic chairman, Dr. Chitra Ramurthy, has given me the opportunity to introduce our next speaker, Dr. Samina Zamindar. She is a cataract surgeon and a comprehensive ophthalmologist at Zamindar Microsurgical Eye Center, Kalyan Nagar, Bangalore. Dr. Zamindar is a proficient phacoemulsification cataract surgeon and won the best eye doctor in Bangalore at one point of time. She was one of the early adopters, I think since 2000, if I'm not wrong, of the revolutionary phacoemulsification cataract surgery to be started at Bangalore. She has played a major role in NABH accreditations of many hospitals of our country. And I think she's one of the best persons to talk on managing accreditations. Over to Dr. Samina, madam, please.
Could you share? Dr. Samina, you have to unmute yourself.
Am I audible, Dr. Chitra?
Yes.
Yeah, you're audible, madam. Go ahead.
Thank you so much, Dr. Srinivas, for those kind words. Dr. Chitra, I'm having a lovely afternoon, evening today, thanks to you and your dynamic leadership at LDP. There are a few things which I think few people don't know about me, and I'm very happy to share that I do adoption-related pro bono work. My hobbies are acting, poetry, and visual thinking. And yes, like Dr. Srinivas said, I like to create awareness about quality and safety in healthcare. And my key to success is if you try, you might. If you don't, you won't. So the topic given to me by Dr. Chitra today is managing accreditation. We are now in our 7th year as an NABH accredited organization. And I would rather slightly coin this term differently. After an organization becomes a slightly more mature in its journey of accreditation, it no longer needs to manage it. It happens as a way of life. Quality can sustain only if it is a cultural change. So the first and foremost, I think we have already heard the eminent speakers, Tulsi sir and Dr. Rajshekhar, talking about how important it is to take care of your team. The hospital environment and the staff should feel psychologically safe and valued. That's the first and foremost thing. It so happens that Rome was not built in a day, and we all know that. So nothing, even an accreditation, an entry level or your eco standards, nothing can bring any quality or cultural change in a day. In fact, do not rely on that to bring in any such change whatsoever. While we are talking about accreditations in an LDP platform, I would like to share that I chanced upon a management course at IIM Bangalore recently. And there was this very pertinent question by Dr. Chitra, whether you should have a manager running your practice or you as a doctor should be leading your practice. I believe that in a mid-sized practice like ours, we should, if we cannot hire a manager, an MBA to run the practice, should take a few days off and take a management training. Completely like what Dr. Tulsi said, he already has a wonderful training every January, or you can do it wherever it's convenient to you. And the first lesson, what I learned in the management training is that if you think as a youngster that now you want to start a practice because you don't want to work for somebody, you want to be the boss, then mind you, friends, you are never a boss in your organization, especially if you're the owner of the organization. Everybody around you is the boss. And the second most important lesson, what I learned is that your only responsibility through the day is to remain calm. Completely calm. You will have to have a spiritual aptitude or do whatever you have to do, but stay calm through the day. And that's the most important quality of a leader. This is what happens, especially after, you've just finished your assessment and now you feel, oh, there are 3 more years till the NABH assessors land at your doorstep. In my journey as an accredited organization and as an NABH assessor, I have seen quite a few of these instances of complacencies. And how do we actually get over it? We get over it by this feeling that accreditation is not the way to get quality. There is something beyond accreditation what we need to work, because every day is a new challenge. There is no such thing as happily thereafter. If you see this picture, this is actually of Juliet, and you can see Romeo sitting over there. Do you think Juliet is really, really very happy? There is really nothing like happily thereafter. And there is frustration. There is a stomach ulcer, which you will have to face, and you cannot ignore those symptoms. But slowly and gradually, as you develop this practice of becoming calm and take leadership as begins with leader engagement. You as a leader, how much are you in tune with your staff is the first and foremost thing. So you need to consistently encourage, motivate, and reward innovation. Introduce new and improved ways of thinking. So if we have to now come down to the basics after I gave you this initial introduction of what I want to say today about total quality management, this is the roadmap what NABH talks about. Visibility of available services, for example, signages, standard operating procedures. Do we really have standard operating procedures in our organization because we really want to have standard operating procedures, or because it is a standard of NABH? That is what we need to understand. Because if you are a true believer of standard operating procedures, that is the fundamental grassroots level improvement you can have in your quality. You no longer need to manage accreditation, because if that is in place, most of your things are in place while you are implementing accreditation standards. Of course, surgical safety guidelines, anesthesia safety guidelines, documented and implemented, like what we commonly say that we rely only on God. Rest has to show documentation. Handling medical emergencies, trained HR, medications, equipments, define admission inpatient care, safe and organized medication process, biomedical waste management, hospital infection control meetings. I sometimes am accused that I support NABH too much, and but if you really know, do you know that as a healthcare organization, if you really want to abide by the pollution control board without NABH, we're not talking about NABH, you're supposed to have a monthly hospital infection control meeting, and you need to document the minutes of the meeting. If you're not doing that, and if you end up having a cluster or even some patient suing you for endophthalmitis, they will look for your HIC meeting notes, because that's a part of a mandation from the pollution control board. NABH has nothing to do with that. Now, I want to just throw in and toss in some terms over here. Tulsi sir was really very nice to actually share with us what is happening at Arvind Eye Care System, and he spoke about lean. So just again reiterating the fact of what is lean. Are we looking at our organization and wanting it to make it lean? So what is lean? For the uninitiated, I would like to say that lean is the systematic approach of eliminating waste. And who can guide us about eliminating waste? Will I know about waste at the reception level, or waste in the optometry room, or waste anywhere else? No, I might not be the right person. I need to talk to the person who is doing the job and ask that person's opinion if I need to remove waste and make my practice waste-free. This is a word, muda, which is a Japanese word. Waste is any activity that consumes time, resource, or space, but does not add any value to the product or service. Now, this waste has to be identified at each and every operation and at each and every interaction of the patient in your organization. It's a wonderful, wonderful exercise. You can actually do this. Lean management in healthcare is definitely a possibility, and definitely an idea with which we all should get warmed up. Rather it be a single standalone practice, a mid-sized practice, or big chains like Arvind. Lean management will include development of a culture of continuous improvement, empowerment of employees, and reduction of waste. Long back when I was just starting my practice, somebody had told me these words of wisdom that the way you talk with your staff, that's exactly the way in which they will talk with your patient. So you really need to examine how you are going to talk with your staff. And concentrating on these values is expected to result in decreased cost, enhanced safety, and improved quality of care. There is a rapid process improvement workshop, RPIW. I'm just tossing some ideas over here because it's about time that we look at management. Too bad that in medical school, we were not taught about management. But so what? It's never late to learn. This is generally a week-long event. You remove, say if the most common problem, say, is waiting time, and now you want to work with patients and their families and reduce waiting time in your organization. You can do this RPIW program, just tossing some ideas, do read up about it and think about implementing that. 5S explanation. That is the first thing what you need to continue doing even after your accreditation journey has started and you know that your assessor is only going to come 3 years down the line. First, sort out the things, set in order, shine, standardize, and sustain. Sustain, sustain, and sustain, right? It should become a way of life, a part of your daily work. Something like Gemba. A concept of Gemba is interesting because a manager is walking around the hospital floor. Now, if you really don't have a manager, you empower your own staff. Instead of imposing somebody from outside, now doing Gemba for you, you empower your existing staff to the next level so that he does this. This concept of Gemba is actually practiced in your organization. He's walking on your hospital floor and speaking to the frontline staff and understanding their problems and shortcomings as a way of daily routine rounds. Kanban is just-in-time inventory, scheduling, and seeing that you do not have excess storage space for inventory, which you're going to use over 2 years' time. And standard operating procedures is something which we all should adopt at every level in our organization. There is a small 40 minutes webinar which I've taken, which is available freely on YouTube about how to make SOPs for your organization. It might be a wonderful way to start your quality journey. do need to analyze risk. So the first portion of if my talk involved lean management, I come to the second portion of my talk where I talk about risk management. Risk analysis is the simplest way in which you can do risk analysis in your own organization is that right now, please close your eyes and try to see that, and imagine yourself walking through your organization from your parking, entering your gates, and seeing what are the probable risks you will face as a patient in your own organization. There is nobody better than you to decide what are the patient risks in your organization. Once you've identified those risks, you are looking at the likelihood of these the risk happening in your organization. It is almost certain, likely, possible, unlikely, or remote, and the severity of the impact of these risks, whether it's extreme, major, moderate, minor, or negligible. Extreme being leading to death or permanent incapacity. When we are talking about eye care, maybe it's endophthalmitis. So once you have sort of categorized these risks, then you look at how do you actually take steps to reduce the risk. And even after you have taken steps to reduce the risk, do you think that the risk will never happen? Of course, it can still happen. So your risk readiness, are you now ready for the risk? This is all what encompasses managing accreditation, rather than going into the boring details of the standards and how do you really continue your accreditation journey. I thought if you understand the core and ethos of what accreditation means, that is better. So after we've spoken about risk management, let's enjoy this small video.
Tomorrow never comes is right. A day when there will be a tomorrow that will never come. But between that tomorrow and today, there will be many tomorrows. So when that time comes, when that tomorrow will not come, until then you have a lot to do.
I hope you all understood what this gentleman was trying to tell us. So that is what all about communication. You know, NABH has a standalone standard for communication. And unless and until our communication as a leader with our staff, communication of the staff with patients, communication with doctors with patients is not very clear, there is no way in which we can grow or abide by any such standards. So is it enough now if I have to request you to close your eyes and think, is it enough the communication at all levels in your organization? What would your answer be? I think my answer is no, it is not enough. It's a continuous journey and I'm continuously struggling and striving to make my communication perfect. How do we really achieve effective communication in our organization? The importance of right attitude towards work and value of patient is again very, very important. How does our team perceive work? Work is burden or patient is burden? Then any amount of training will not really help, because this is the root cause for them not imbibing any such training. This is where we need to start all trainings first to understand whether work or patient is a burden. And teamwork has to be acknowledged. You can only be as good as your team. Communication training is negligible. I'm giving these random statements over here because I believe that it is negligible. When did you last do a communication training for your staff? This was a training which we did some time back before the COVID pandemic hit us. And this gentleman who came in and taught us about communication told us that the verbal communication is only 30% important. Well, the other communication is your body language and the tone and tenure of your words. And that is what we want to teach our staff. So the communication errors are the major cause. 60% of medical errors are communication. Why do we talk about adverse incidents in India? And why don't we have the 60% of medical errors communication? Because we do not really have an incident reporting culture in our country, unfortunately, if I have to say that. Only 3% of adverse incidents are reported. To first and foremost develop an incident reporting culture in our organization is another very, very important step in quality improvement. This kind of culture where you do a root cause analysis for every adverse incident and set in preventive action will reduce conflicts with staff, patients, and families. And if I have to now tell you that what we have learned in our journey as in communication is respond, but never react. Your patient might be angry for multiple reasons, but you are supposed to respond and never react. Put yourself in their position, empathy, and a training of empathy for your optometrist staff becomes very important. The same line of communication in case of an adverse event. Nobody should jump the hierarchy in talking to the patient, especially if there is an adverse event. And an ideal communication implies building trust, transparency, accept your limitations. You are not God, definitely. See that your patient is involved in an informed decision-making. So consent taking also, these are all different standards of NABH coming together to see that you have an ideal communication at your setup. Control your own emotions, stay calm, and stay calm. Everybody has two jobs at Toyota. I enter now the third portion of my talk. That is Kaizen. How do you continuously improve quality? Because after a while, when the assessors come to your doorstep, they do not say that what have you done and whether you are maintaining the standards. They will ask you, what was the quality improvement? What have you done? What is new? What growth have you achieved? And this is very, very important that everybody, each and every person from the doorman to the chairman will do work and will improve work. Think about that, not once in 3 months when there is a quality meeting, but every single day, everybody is empowered to do work and improve work like how we see at Toyota. These are some picture of the Kaizen meeting we have. Kaizen is a Japanese term, I'm sure most of you know over here. I know that there are very, very senior and respectable people in the small group we are having right now, but I believe that this is going to be seen by young ophthalmologists, and I take the liberty to discuss this right now, that Kaizen means incremental improvement, and give the onus of these incremental improvement to your staff and see how beautifully they will come up with some novel solutions. We had a problem that, we had at some point 10 years back, our surgical mops, the OT mops, where we started autoclaving the mops also. The reason is that Bangalore is, it's raining most of the time, and how do we really sun dry them? So when we realized that our culture plates were showing some growth continuously, we did a root cause analysis and we said, let's eliminate these organisms. So how do you go about it? You actually do not recycle your bacteria, your germs. You kill them by a complete kill kinetics. You autoclave the mops. And we started doing that, and surprised that idea was given to us by an OT staff. And after we did that, by the grace of God, over the last 10 years, our OT culture plates are really good. So this, I think I've already discussed, incident reporting culture. There are no mistakes in life, only lessons. I know about certain organizations who actually give incentive for reporting an adverse incident instead of penalizing that person. There are no mistakes in life, only lessons. A clinical audit cycle is a part of your accreditation. Clinical audits you need to do at your pain areas. And once you do clinical audits, you really try to benchmark your practice and reach to the second level of excellence. Make your center the center for excellence, especially if you're doing clinical audit in the core areas of your work. Staff appraisal, training, privileging, continuously doing that, seeing that your staff feels very proud to be working in your organization. And of course, review and retraining continuously. This is a continuous process which keeps happening all the time. Patient feedback and versus patient experience. There is an NABH standards where you need to say a patient satisfaction surveys. Do you really want to do it as a part of NABH, or you want to do it to really improve your quality? NABH assessor will reach your doorstep maybe once in 3 years or once in a year for surveillance assessment, but your patients reach you every single day. If there is somebody appointed just to ask your patient, even your happy 6 patient, if they are taken aside and asked if there was some scope of improvement in my center, what is it? Please tell me. There is some small thing they will tell you. And that small little thing, what they tell you is something what you need to work on to convert this patient experience into a patient delight. Optimum use of resources. Again, we have spoken about lean management, and that speaks about all resources all the time. done everything, please keep continuous watch over what are the critical functions of your organization. In an eye care organization, I presume that's the operation theater. Having CCTV cameras in areas where you are doing, we have your TSSU, theater-based sterile surgical unit, where the washing, cleaning, and drying of your instruments happen is a very great idea. You might not look at the CCTV, but why not? And I will leave you now with these final thoughts that what can we do as leaders? Ask for Kaizans, help create time. You can't expect that some staff will give you Kaizen after continuously working back to back for 8 hours. No, create time for Kaizen, create time for these activities. Throw in some chai and bhajia once in a while, maybe once in a week, and say, let's do Kaizen now. Lead by example, get involved, be the coach, mentor, and leader. Go to the Gemba, to the workstation, or see that if you are not going, there are capable leaders who are respected in your organization who go to the Gemba. Teach root cause problem solving, follow the clinical audit cycles, and recognize and celebrate Kaizen. Aldo Gucci once said that quality will be remembered long after the prize is forgotten. I agree with that. So if you have to raise your consultation charges, I think our organization in Bangalore is one of the highest paid. We charge the highest for our consultation charges, but that's all right. You need all these things, all the quality efforts. It's not cost effective. You need to charge where you need to charge, and you need to let go where you need to let go. But never feel shy about charging your patients because quality will be remembered long after the prize is forgotten. I'm not saying this, Aldo Gucci is saying this. There's one more thing which I remember now that Peter Drucker said, that a hospital is the most complex organization, and you need to continuously learn and learn more to be able to be the able leaders of your organization. I can be only as good as my team. So I thank my team profusely for helping me and supporting me all the way. Thank you so much. Again, Dr. Chitra, for giving me this opportunity. Thank you.
Madam, you're muted. Chitra, madam, you're muted.
Thanks a lot, Zamina, for an amazing talk you gave. And I'm not bothered about how many attended this session, but I'm glad I was part of it. But let's get to some practical question. Many hospitals apply for NABH, but they do not sustain the process beyond, and it starts getting diluted. So can you very briefly tell your thoughts as to why it is so critical to keep it going?
Ma'am, I believe that we should not worry about NABH because of any external benefits of NABH. We should think that we are in a quality improvement journey, and NABH is a byproduct.
Yeah, true.
So if that happens, and there is a change in the mindset, we are talking with young ophthalmologist now, so I feel that they will take it in the right perspective and just start their quality improvement journey. NABH will just happen as a just matter of coincidence.
Yes, true. And that actually puts many of the systems of an organization very much into place. And Anaga, you had a question before we go on to our last speaker. Anaga? You had a question, no, Anaga?
Actually, the question I had was, what should be the ideal growth rate for a mid-sized nursing home or a clinic in various levels of its evolution? Obviously, in the beginning, if you start, the growth rate would be higher. But as you step up the ladder, then what should be the ideal growth rate that should be maintained?
Whom should you want to answer? Dr. Ardier?
Maybe from our experience, I can say even mid-level, maybe like the first year, as you start, as you go on to the next year, it may be like 15-20%. But third year, you should see the maximum, like 30 to 40% growth. After that, probably it may start coming down. But the real growth happens in the first 3 to 4 years.
So what about 10 years, 15 years, 20, 25 years?
If you're able to double the volume from what you practice, like, the first year is kind of for setting it up. Second is your real year in the practice. I think the next 4 to 5 years, if you're able to double that volume, then you are really set. After that, we look at about 5 to 6% or 7% is what we really look at for all the mature hospitals.
So after 10 to 15 years, it would be somewhere around 5 to 6%.
That's, yeah. But having a higher growth rate is it's good. But the real constraint, what we see in our hospital is the real estate. How much space we have to accommodate patients. That becomes a real stumbling block in many places. For example, in Madurai, we have been stagnating, but once we doubled or tripled our OPD space, it went up the next 2-3 years, we were growing by 15-20%. So before that, it used to be 3 or 4%. So
yeah, many times the increments that the staff usually expects and demands is much more, and the growth rate of the organization may not be that much. So then it becomes probably a matter of concern how you can, year on year to give increments to staff also, because they feel that you are growing.
Sometimes I feel that having appointment is also kind of blocking on the growth. You really may not know. So once you start giving appointment, the appointment is based on constraints. Okay, but if you say that we are going to see everybody who walks in, I think then you know what is the real demand for your services. Otherwise, you will never know.
Right, absolutely, sir. Absolutely.
Sir, but constraint management, when you look the appointment into the system, of course, many people who are affordable, they also want to come into the system. And so how can we try to make a balance between the appointment system and the non-appointment or the walking system? That itself is the constraint management, right?
Yeah, correct. You can someday do a scheduling of your patient and also you have to respond to that by increasing your resources, either in terms of human resource or in terms of space. Maybe I'll ask Tulsi, who probably will be able to give a better answer than
Yeah. I mean, on the notion of growth, I would say that it's a function of two things. One is assuming that the quality is there and things like that, of your capacity and also efficiency. And like RD said, I mean, appointment is like a double-edged kind of a process. Now, at one level, it may give you the peace of mind of uniform patient intake, but at the same time, it is also a gatekeeping mechanism. So it really controls demand. So you really don't know where you are, what your real demand is. So that is something to really be reflecting on. And then usually so at sometimes we have the judgment saying that, okay, it looks like I need to expand. The patient, the capacity for seeing patients. And the second question about your challenge of giving increments to patients while the growth is not that much. So I think that's what you meant. Usually, what we are seeing is that because of advances in technologies and surgical intervention, diagnostics and procedures, even though at Aravind we don't change the consulting fee often, or even our surgical fees often, maybe once in 5 to 10 years is when we change the rates. But in spite of that, our revenue growth far outstrips the patient volume growth. Now, if the patient volume growth is 5 to 7%, the revenue growth will be typically 20%. Now, that is essentially because the mix changes. You are now having more investigations that you can perform, more diagnostic capabilities, more intervention capabilities. Right. So that is how I think you'll be able to sort of meet because any organization as it ages, the costs will go up.
Right.
Those are all realities of life of running an organization. Yeah. So which is why it is also good to have a healthy turnover of staff. Holding on to staff at any cost. You want to hold on to good staff. I'm not saying you should let go of them. But then somehow by paying more, somehow keeping the staff all the time, there may not be also, you want a healthy turnover. You also want new blood to come in. Right. So all those would be strategies to manage the staff cost and things like that.
So we shall now go on to our last speaker, Mr. Sudhir, who's the CEO of Maxi Vision Eye Hospitals. Sudhir brings with him a very rich experience of over 20 years in eye care business management, and most recently was Director of Operations in Vasan Eye Care Group, where he has worked for 15 years. And during his tenure at Vasan, was responsible for establishing and operating more than 82 eye hospitals across India and Sri Lanka. And in particular, he was directly involved as a business head of 50 eye hospitals in Tamil Nadu and Kerala, managing over 150 ophthalmologists and 4,000 plus employees. Briefly, has also been involved in establishing IQ super specialty hospitals in the North and was part of their leadership team. And I think he would be the right person to talk to us on driving patient centricity. And we are truly happy to have you with us today, Sudhir.
Thank you, Dr. Chitra. Thanks. Thank you very much for inviting me to talk amongst the stalwarts in ophthalmology. I'm also extremely privileged to be amongst my very early mentor in ophthalmology business management, Dr. Ramamurthy. So coming to my topic is, I'll just share the screen.
Yes.
So the topic given to me was patient centricity. Can you see the screen?
Yeah.
Yeah.
Okay. So my experience predominantly is mostly with the corporate governed eye hospital system. So my views and my opinions may differ from various other stalwarts' opinion, because predominantly I worked in corporate governed eye hospitals where the system processes, brand positioning, everything matters. So I've been privileged to talk to various investors from various countries. And what I can just start with is like ophthalmology services, they all categorize as a take care service segment. It is more like they categorize it as ASC and service segment. And also the patients are, the gap between a patient and the customer is narrowing. So the patients
Please
today
everybody to mute themselves. Yeah.
So the patients today are behaving more like a customer in any other service segment. Their demands are high, they are much educated, they are much informed, and they are like earlier what used to work as word of mouth, what we call as, now it is more of word of Google or word of digital. People look at various opinions, various messaging in the digital front also, because thanks to the penetration of smartphone to around 40% into this. So patient is primary important. So I would just briefly just take you what is the difference, broad difference between a patient and the customer. Eventually, when the gap narrows, we should also understand we'll always be one thing, certainty with us is patients are always driven by need, but the customer is driven by desire. That's the primary advantage for us. But then there is also, every patient is unique for us. But customers are, and our patients, we have a high risk on legality in terms of medical legal, but whereas the service segment doesn't have, they have only low risk on legality. So then there is a high scope of retention of a patient. They all say like we have, ophthalmology is more about, we are fortunate to have 2 eyes to operate, and around 40 years of one patient can be managed effectively with us alone as a loyal patient if we do put the right strategies in place. So this is what a survey we did way back in 2009, just before expanding our network to South in Tamil Nadu especially. We actually had a calling exercise to run 20,000 patients in 3 different states. It was a sample survey. And a general notion was like patient always goes to a lesser rate or free charity, or the patient's preferences are more toward charges or the cost of the surgery. But what we found was patients first want, please read it anti-clockwise. The patient first prefer a good surgery outcome. So they take enough and more of referrals for who does the best surgery, what is the best outcome. And then also they want experience in communicating doctors. That's what many of them express, that doctors should spend more time with the patient. And then they also look at which is the nearest hospital to them instead of traveling a lot. And then they also, if they're employed with the government or private segment, they also look at their insurance or whether it is reimbursable. Then once they experience, they look at also ease of service and access. So how well we are serviceable, and how it includes all waiting time, access, getting an appointment, everything. Then once they step into the hospital, they also prefer like attention, guidance, and priority to them. Every patient wants their own priority. Then they look at ambience, the comfort, the facility, as earlier speakers were mentioning. Then if it is an IP case, they also look at whether clean wards are there, whether the facility of nursing backup is there, then cleanliness. These are the normal. Then ultimately, the last is whether the charges are not very high or whether they will be able to get some concession on various grounds. So this is the traditional approach. Now we have a traditional approach. Hospitals had assigned departments and they had company defined process, and we expect the patients to walk through our own defined processes. And then there were defined channels of communication. Now it has actually evolved into multiple channels of communication. And today it is mostly customer defined process. We are customizing in corporate chains. We are customizing our process to meet the expectation of the patient, not compromising quality, not compromising the processes, the clinical processes or protocols, but many of the operational processes are more customized to the patient needs in every market. We analyze that. Then we have earlier it was a business hours for many hospitals. So I'm talking about 10, 15 years before, it was like hospital function from 9 to 5, patient should come in 9 to 5. Today, in our network itself, there are hospitals which function from 8 to 6, some hospital from 8 to 8 or 8 to 9 also, as per the patient need. Then there is interaction. Interaction is much expected today. There were limited interactions. Now the patient expect more interactions. So today it has evolved itself rather than inside out approach to an outside in approach. So these are the various touch points which earlier speakers were also mentioning. So which actually evolves through the first impression for the patient. Then they have a need generation. Then they make a consideration. They also look at, okay, whether to choose this hospital. They might have checked with other hospitals also. Then in that process, we have to, the boxes are mentioning how we should make that need generation, how we should convert a patient to our own, that is the initial consideration. Then comes the experience part of it, as the patient is booked with us for a consultation or surgery. Then we have to do a lot of strategies around the engagement of the patient. Then actually evaluation, putting all the processes right in place. And then the patient makes the moment of commitment, which happens mostly on the counseling side or on the doctor's side. And then post-service also, we have to see that this patient becomes our own loyal patient. They come back to us. We get a repeat patient, what we term as sticky patients. So they come for cataract, for example, they come for other eye also with us. And if they have a retina intervention, retina treatment to be done, they choose the same hospital or for their other procedures. And then they choose their services or the eye care services of their family members also to the same hospital. This all happens, which we call it as a brand obsession. So these are the other strategies what we should do, work on towards making patient brand obsession. So this is where I would like to what is a brand? Actually, brand is something which builds upon the identity. Brand or branding doesn't necessarily mean only TV ads or paper ads or print ads or communication. Brand is also a single person also can brand himself. Brand is what the particular entity or the service or the product is known for a patient to choose. So this is what is the ultimate outcome of any brand. Like brand evolves with quality, price, custom, longevity, accessibility. But brands, finally, the end result of the brand is brands are trusted. Brands are which people use repeatedly, and brands are something where a customer or a patient connect himself towards some reason, some values. And brands are also visible. So whether hospitals should be brands, or what does hospitals should do to make itself as a brand? Doctors, results, surgical results, the experience of the doctors, quality of surgeries, what you are doing, people should know. Technology, if you are investing, people should know. And your transparency, you should exhibit it. And whatever patients, whatever caste, create economic segment of the patient, every patient should be accessible to every procedures or treatment. Cost also should suit the various economic pockets, and then the service should be world class. So this helps patients to build trust on the brand, and also they will come repeatedly for you, and they will also have a connect to the particular brand or the hospital or a doctor. And then it should be visible through various communication exercises. So this is something which I wanted to display, like how brands, they both are, each segment, there is an electronic segment, there is a retail segment, there is an online segment. So if we see, both these brands enjoy different positioning. Apple is an ambitious brand. People buy Apple irrespective of the price. Much better than Samsung may be available at a cheaper price. So Chroma is chosen for more trust. rather than Reliance Digital, which is opted for cost or schemes or whatever it is. So likewise in online, where people pay in advance, people pay blindly in advance to an Amazon, but they prefer more of COD. The studies have told that Flipkart is more of CODs. So Apollo, like in hospitals also, Apollo enjoys a reputation in the multi-specialty, whereas Fortis is known as a different entity. For automobile, the connoisseurs buy Volkswagen or a Mercedes, whereas Hyundai is an economic segment. So everything has got their own position. So similarly, how can a hospital position? So in our business language, any business, or even hospital, if you consider it as a business, we should look at whether it is sustainable and scalable. This helps in growth of the company or the hospital. So what are the factors which are sustainable, which we can grow inside a hospital? Whether doctor profile or like I say, a particular doctor's profile, yes, it can sustain. The name goes long for generations, but it cannot be scaled. That particular doctor cannot be able to move to every location if you are planning to expand. And the cost economics of promoting a doctor is low. Technology it is not sustainable, because today you invest in one technology is ever evolving. Tomorrow that technology, another superior technology may come. But scalability, yes, if you template it, you can scale up with a model, we can scale up with the technology. So, but the investment is very high. Surgical quality, sustainable, yes, but scalability, you may not be able to provide a uniform surgical outcome in every centers if you are having a network practice. Every center. So it is important, as the other speaker was mentioning, to set up certain templates, surgical audit, everything, to see that you parallel the skills in any of your hospital, people get the same outcome or more or less the same. Infrastructure size, people build larger sizes, whether it matters. Whether it is sustainable, no, it's not sustainable because it involves high investment. Scalable, yes, if you go with a standard template, you can scale with standard template. Like we do have a templating of secondary care, tertiary care, primary care. So depending on the market and the size of the market and the acceptance of your brand, you can choose it. Pricing, it's never sustainable because price competition never ends there. You do something for lesser price, there are several other people who will compete with the pricing. Ultimately, you won't get any benefit out of it. Scalable, yes, with a standard pricing model, you can scale, but it is going to cost your P&L. But finally, what is coming as a sustainable and scalable is trust. If you build your brand and build a lot of trust building factors around the brand, the investment is low and it is sustainable and scalable. So today we all are familiar about B2B and B2C. These are models of business to business models, business to consumer model. Today it's all about, the latest is about H2H. Every business, whether it is B2B or B2C, you should also involve, there is a human in that. So it's also called today as H2H, human to human. So this is where we look at the decision element. This is the EI, emotional intelligence science, which actually all our strategies should be aimed to influence the right side of the brain, wherein the patient stands loyal with you and they will be, the trust builds on the right side of the brain. So how do we build trust? Through better communication, honest communication, build a lot of empathy in the system, do a lot of follow-ups to show that you care, personal attention to show that you are important to us, and doctors share time to see that, because ultimately, though our processes ask for a dilatation and optometry, and then only they see the doctor, the patient has come to you to see the doctor. So it reduces the time between the processes. Ultimately, that is what they come for. And never worry about the waiting time to see or the time spent with the doctor. Patient will be never worried about spending more time with the doctor, but patient will be worried about the idle time. We call it as process time and idle time. Patient will not worry about when he is getting investigated on slit lamp or any op scans or anything, but patient will be worried for the waiting time between an optometry and a doctor. That is where the patient gets irritated the most. So then hospitality, yes, it's very important. And that has to be starting from the security till the doctor. So this is the anxiety chart which we have analyzed about that. The one of the above line which shows the patient anxiety levels, that's the light blue line. The dark blue one is where how with the right kind of a process, we can bring down the stress levels of the patient. So each of these are very high stress point. Entry, for example, entry of a patient to the hospital is a high stress moment, because he would already been having cataract or eye pain or injury. So then stress will be at its peak. At that point of time, if the security doesn't open the door or security asks him doesn't give him a proper parking space, his stress level shoots up. That is where you should groom your security also to treat the patient greet the patient, allow him to facilitate his parking because he will be in an urgency to come into the hospital. When the registration, talk to the patient well, you can ease the stress. And during the waiting, the patient stress level goes again until he meets the doctor and get to know what has happened to his eye. And then the optometrist with a proper explanation, a preliminary explanation, which is guided and trained, they can ease the level of stress. Then comes to the doctor. Doctor can ease a lot of stress by giving him the verdict, what he has come for, and it's solvable. And then again, a dilatation. Dilatation is the most insecure moment for the patient. For any one of us, both eyes closed is the most insecure moment. Only the brain works and they start thinking about too many things. So at dilatation, there should be someone to talk to the patient, ease them out, and tell them, periodically check the dilatation status, everything. Then comes the investigation. Investigation, there will be a lot of ambiguity, what has happened again. Then the counseling, then again it is done. So not going further, ultimately when the patient goes out and the discharge, the stress level should be low. That should be, our processes should be designed to meet and depute touch points in each of the stress spikes level. I'm sure you will agree, these are the most of the touch points, and these are the areas where their stress levels are high. And if you put right people at the right person with the right script, you can send every patient back home with a good, as a good influencer of your brand. So these are the, again, I'm reiterating that the first step of welcome process, which actually imbibes a warmth and transparency. We should aim for a warmth and transparency. Second is the value their time. We should always value their time. Many of the eye care patients are mostly taken permission from their hospitals or works or from their offices or in business. So we should value their time and see that how fast you can send them out with a proper process. Third is about clinical command. Never let go of your clinical command. Patient should not be able to dictate, I read in Google this, I read in Google that. Here I would set an example of our founder, Dr. Kasper Reddy. He always tell, this is my version. You can always check with Dr. Google. He always tell that it's a script to the patients. So this investigation, doctor counsel, this all we should never compromise on our knowledge or command. Then there is ultimately a take-home field. The last process in any of our hospitals would be optical sales and pharmacy sales, where we should not irritate a patient, because that is from there only they go home. So they should go with a pleasant feel of the hospital or the brand. So these are some like trust. We call it as trust capital. So the trust capital is the very important capital inside any hospital, which is constructed with empathy, transparency, ethical practice, and surgical quality. What good investment we can make or we are making in a corporate chains are artificial intelligence. We have a data analytics team perfectly analyzing the data and devising operation strategy. Because as somebody told earlier, ophthalmology, we still are learning. Though this is my 23rd year in operation, but yesterday also I learned something. So this is how we should consistently be on data and study the data and do business intelligence and analytics for the business, better driving of the business, and also facilitating the right investment. Whether LASIK is required in this market, are there patients for it? This all comes out, proper decisions comes out with business intelligence. Customer intelligence is also very important. Sometimes many markets behave on community base, sometimes on caste base, sometimes on cost base. So there will be there are incidents where some hospitals have created lot of endophthalmitis, series of endophthalmitis. Generally, the fear of eye care itself would be there. So this customer intelligence is very important in frequent surveys for data informatics to navigate the business in right direction, and practice and train emotional intelligence. So this is how we track like loyalty. Loyalty was 5 years back. Loyal patient was very important for 5 years, but then it came ambassador of patient. Today, companies, corporates work on making influencers. That is, we call it as brand obsession. So how you can make every patient an influencer for another patient to choose your hospital. So this is what we term it as patient relationship management. So we track like service obsession to a brand obsession across all these segments. So what are the ingredients? It is 4 P's, like processes, right processes, and passion inside the team, and people develop right kind of people inside the system, and treat all the patients equally and in standard. So this is care. We all talk about care, but this is the DNA of any good service industry is about care. But we have further engineered this DNA and also defined what should be the care standing for. So care is first talks about culture. The brand itself should have a culture. What should you be known as? So you should try to first devise, that is your vision. Like my brand should, irrespective of spreading our geography or locations, our brand should be anywhere, it should be known for a particular culture. So then attitude of people, you can't expect everyone to behave in the same culture. So while selection itself, you should look at attitude of the people whom you are employing, whether they will fit into groom your organization to the culture what you want. Then there is respect. Respect is interpersonal, it's universal, it's not interpersonal. It's not important that you respect only your boss. Respect should the patient, respect to the instruments you are using, assets you are using, that you should also always inculcate that culture inside. Then empathy. Empathy should be driven through trainings, and empathy is more important in the treatment itself. So this is spatial care. Where earlier speaking, we always look at hospital operations such as sensory. We do call it a sensory marketing. For touch, feel, warmth, everything matters. So we should also look at what the look and feel of the hospital, the grooming, the facilities, the communication of the patient, direction boards, design of the hospital itself, ease of design. Like for example, we don't use darker paints on the walls or wooden furnishing much, because it gives patients who are coming into our hospital are already half blind. They came here for proper vision. So they should not feel even more darker while coming to hospital. So put enough lights in the hospital, make more glass system. The infrastructure designs are more glass, so that a lot of perception differs. So this is what we can do in infrastructure. The other one is process care, where you inform the patient transparently about everything. You are going to get surgery operated. What is the lens? What is the outcome? When it is expected, multifocal, what time it takes, progressive adaptation, everything should be informed well in advance. And tariff, why you are paying this, why you are paying this much, or why you are paying so low. It should be informed to the patient. And billing processes should be, every transaction should be billed so that the patient doesn't feel this. So then another one is communication. There should be a free, every patient, every staff inside our hospital should be a listening post. Not that particularly directing this, I don't know, please stop, go to that room number 3 and to get the answer. Everyone should know everything. We call it as escape. In our training programs, we teach every staff about what is cataract and what is the treatment for cataract, what is the surgeon profile, everything. So there should be a free channel, and every patient doesn't know which department, who is qualified and all. We should be able to answer. Then further explanation can be given by the experts. So we look at also measuring. Earlier, I forgot to mention, every complaints of the patient also should be recorded and noted. We have a digital system. We have a tablet which has got a small software which all the touch points are measured by asking the patient yes, no, and rate it between 1 to 5. We tabulate that and we see where exactly in facilities, whether it is in registration, whether it is in billing, we measure that and try to improve the system. Another thing is, like, even we encourage even our doctors. Sometimes the patient come very enamored with the doctor. The doctor humbly request, okay, whatever your feelings are, please put in Google, because Google has become very important tool now today. As somebody was mentioning earlier, if you have to reach, if a patient has to reach your hospital also, when he clicks the map, the first thing which comes is rating. When the rating comes at 3 or 2.5, then the patient obviously will be curious to see why it is 2.5, and they go down. And then they see the complaints, that makes the perception, initial perception itself for the patient. So it's Google has become very important, whether we like it or not. So we should see that the Google ratings are up, and we also, our ratings are measured, and try to do the best ways, ethical ways, to improve our rating or visibility to the general digital world. And also we should know transformation is very important. There will be always, in any organization, there will be backbenchers who are not strong will to do what you want. Then there are influencers. So create large, we can't change the human being. So you have to create a large team of influencers in every system, in every branch, so that they influence these backbenchers and bring everyone to this thing. So there should be a skill-will grouping. So skill, you can teach them. Will, it's very difficult. It's an attitude. So you reduce the people who doesn't have a proper will to do the way you want, and do the training, then recognize people, then do the proper appraisals on qualitative parameters. So this is how you cultivate culture. So basically it's a team building. We define it as care team and a cure team. So this care team and cure team should work together. It is where managers and the doctors should have a balance. They should understand each other's constraints, each other's objectives, and work together in a common protocol and process, and work towards the common objective of the overall organization. So this is ultimate outcome of the PRM, what is patient relationship management, the brand salience, influences, respect and trust, and a lot of loyal patients to you, which will sustain the business for long. So this is the closing words, work to worship. And that's all from my side. Thank you very much.
Thanks a lot, Sudhi. That was a wonderful talk. Really good. I'm sure all these talks have to be heard once more in solitude to gain some more from it. Very thoughtfully, every slide, every written content had value to enhance our practice. Now, I have one or two small, very tiny questions. I'm sure all of you would want to spend some Sunday with family. To Prashant Gar, in West, once an appointment is fixed, the details, the reading material, some priming, etc., is given to the patient, but that does not happen in our country. Would you advise these younger practices which are evolving to do something like this to sort of take it to a different level?
No, so our assumption is that if we are giving them the material, the assumption is that we are probably aware of what kind of ocular disease are they suffering, which for a new patient may not be true. Yes. The material that probably the first appointment should be the process that the patient will go through, what are different prominent locations that they can contact. However, the moment the diagnosis is made and our evaluation is complete, the patient information material can be handed over by the counselor. So we normally, for a new patient, the material that goes along with the mail is mostly related to the appointment time and the key people that they can contact in case of difficulty and what is the kind of path that they will go through during their examination process.
Yes, I agree. One question to RDR. We know like diabetic retinopathy, glaucoma and all need separate visits, repeat visits. So how would you schedule them differently from the patients in different practices? I know your setup is something so very different, but I want you to think for a smaller practice. How would you advise that they categorize the regular crowd from these who have to come repeatedly to you?
Even these patients, the chronic patients, or for that matter, any repeat visit patient, they are given a card, special card with a date when they are supposed to come. So it's all specified. And the previous day earlier, we even used to pick up those medical records and keep it. And some of the hospitals even kind of, just to encourage these patients to keep up these, we try to make sure that they are seen within 2 hours and sent back home. So they are also given some kind of a special treatment. I think it's very important to do that compliance to make sure that these chronic patients are encouraged to come on a regular thing is very important. And you need to have people to make sure that it happens as well.
Yeah. Are there any other questions which...
Madam, I just wanted to ask one question to Sudhir sir. It's a fantastic talk, Sudhir sir, and Dr. Srinivas here. So one thing is, of course, I want to ask is about the incentivization. There can be incentivization in the form of reward, award, or economic form of incentivization. Do you believe in the incentivization?
It all depends on the objective of your, what is the overall objective of what do you want your organization?
Say, for example, now Dr. Samina Zamindar said that incident reporting, even in an NABH, and they try to incentivize them so that he comes and tries to. Otherwise, why will any other person try to report an incident, which is still a process, documentation, everything is a big process to be done. So why waste time? Rather just keep quiet. So incentivization in every steps. Say, for example, the counselor incentivization, because that is the revenue generating part of any hospital. And then you have incentivization for reporting. It's just one system, what she said. There are many other reporting form of system. And then now you have a vision centers. I'm sure that I asked this question to Tulsi sir and RDR sir, but incentivization, it has a double-edged sword. I agree with that. Say, for example, in case of a vision centers, now what will make these healthcare workers to visit so many houses per day? So in all these things, do you believe in the word economic incentivization in the ophthalmic practice?
See, as a corporate practice, we do incentivize the staffs and various departments based on their various metrics. Like counselors are incentivized on conversion percentage, improving the conversion percentage and also the product mix. Suppose there is a surgeon in the center who is capable to do torics and multifocals in the system. So we train first the counselors about toric and multifocal advantages, and they improve the numbers on that. That is incentivized. In optometry area, we incentivize more based on conversion of the glasses to more promote progressive lenses. And we carefully evaluate that. We have software reports which evaluate that. Then there is the other segment, OT staff. They are mostly incentivized based on their working overtime and as a group incentive, whether the branch has performed certain parameters, whatever we had set as targets, both ways. Mostly ours is mostly on revenue based because corporate. So the overall revenue based, the center has performed well. Every staff is incentivized based on a percentage of their salaries. So it ranges between 5 to, that is what our mechanism, 5 to 15% is shared to the doctors get incentivized based on the specialities they do. Like for example, vitreoretina surgeon, if he visits another branch, he gets a visiting fee, just like any other consultant. So he gets a sharing on the surgeries he does in any other branch. So it's like a private practice. They feel like a private practice going to another branch. And then we do the necessary support system. All they do is perform surgeries, and whatever revenue generated, we share a part of that profit to the doctor, back to the doctor. This is what happens in corporates. It may be wrong, right? That can be debated to that, but this is what happens in.
The same thing I just want to ask now, RDR sir and Tulsi sir. Of course, Arvind Eye Care System is a different model. But coming to the vision center concept, what we are facing difficulty is reaching the target. Say, for example, we want to make these many villages avoidable blindness-free areas. They don't do that much number of visits per home. They don't do that reporting, all these things. So how do you try to rate it in the community sector as well? Not in the corporate section, but in the community section.
For us, the vision centers are run in a very different way. We are not trying to push them to go to house to do the screening and things like that. But instead, we define the villages that are to be covered, and then we monitor who is coming from where. And then we're able to kind of demonstrate that in about 3 or 4 years' time, we have registered 20-25% of the general population. That means at least 1 or 2 from each household would have come in. So if not, we may do something special in those villages more as a campaign. But then the patients are expected to come to the vision center. I mean, that's the whole idea of vision center, not to go again house to house. So we never had to face this issue. Yeah.
Even in your this thing, Arvind models also, you don't have any incentivization, sir, anywhere, right? From the watchman to the chairman?
No, zero.
For the vision center, specifically, the one disincentive is if that center doesn't do well, we close the centers. So we must have closed at least 8 to 10 centers so far. So I mean, it also means loss of job for the person, or they may have to travel for a longer distance. So we always relocate it to another place. So we go through phases. We change the location in the same place. Sometimes we change the personnel in that place. So because we know what is the potential, how many people will be able to come. So if they do it well, it's also an incentive for them to remain in their own village and also still work and get a decent salary from that. So,
Dr. Prashant's thoughts on this?
We do not have any kind of incentivization based on the number of patients seen or other things.
Dr. Srinivas, I would like to reiterate here, like vision centers, basically you should look at what is the vision of that vision center. The institutes primarily make vision centers to reach out to the real, that's more of a community service segment. So if you are looking at vision center to build vision centers for driving in more patients to your tertiary care center, then obviously your metrics or mechanisms to bring in more patients or make them visit home, you should develop maybe an incentive scheme.
Yes, even I agree on that. You have to look at it differently. Every model is successful in a particular way, exactly. As Mr. Sudhir said. That is how you have to look at it to increase your thing. Or have
rightly said, sir.
Yeah.
Yes, madam. I agree with your point as well.
Yeah. So I think we have to conclude. I'm sure it's been a very enriching experience for all of us who wanted to learn so many diverse, all involving processes which are so critical in this business of ophthalmology. And I hope that towards a very small group which was present this time, I mean, our last year's leadership development program had lots of them attending. So if you want to have good programs coming up, you all have to tell your friends to ensure that you all attend it too. I really hope we are able to optimally enlighten you in some areas with the best possible information. On behalf of ARC, we are truly indebted to our expert panel, truly indebted for giving their 2 very precious hours, all top-notch people with great work going on. And I know what these 2 hours meant for them. And I'm so thankful to all for this stupendous 2 hours. My special thanks to my co-moderator, Dr. Srinivas Joshi and Satyajit Sinha for being my right hand always. Our thanks to Sai and Manjula from Numerotech for sharing their Zoom platform for this LDP program. Please, thanks a lot, dear LDP members who are here. Do reach out to us whenever you want anything novel, anything useful, anything different. We would try our best to reach out to the way you want it and how you want it. We would be coming back to you with more modules covering different relevant aspects of the business of ophthalmology and leadership skills. Thank you all. Thanks a lot once again. Thank you very much.
Thank you.
Thank you, madam.
Thanks, Dr.
Thank you, ma'am. Thank you. Thank you all. Thank you.
Thank you. Thank you.
Madam, one thing, we need not be disappointed with the less numbers because these are viewed by many people when put up in the ARC thing. And Sunday being a little bit of family day for most of them, but I'm sure that whatever has been said are really the pearls of wisdom. Yes. And I'm sure that if we circulate these YouTube videos after Sai makes it a different section, it will definitely be a great hit program.
Oh, no, I would ensure that it is actually circulated in different WhatsApp groups. Take your ideas because it's a wonderful session, 2-hour session, and I think every ophthalmologist would gain from it. Thank you so much, all of you.
Chitra, we all learned, Chitra. We also learned a lot.
Yeah. Thank you so much. Thanks.
Thank you.
Thank you.
Thank you, Aldia sir. Thank you, Tulsi sir.
Thank you, Thank you, Dr. Pulsiraj.
Thank you, Sudhir sir.
I think he had to leave. Yeah, Sudhir. Dr. Reddy.
No.
Thank you. Thanks a lot. Dr.
We have our annual program now, madam, now. So
Yeah.
even YLR sir is the president. He is the outgoing president now.
Yeah.
So he has to hand over. So we are having a physical meeting now.
Yeah, I know. No, he was there nearly till the end. Yeah.
Correct.
Thank you,
Yeah,
Dr. Reddy.
Thank you,
Thanks,
madam.
everybody. Thank you.
Thank you all.
Thank you.
Thanks, Mrs.
Thank you, sir.
Excellent talk.
Yeah.
Thank you.
Yeah. Thank you.
Thank you, sir. Thank you.
Thank you.